Chemotherapy, radiotherapy, and surgery have long led cancer treatment for decades by directly targeting tumors. Immunotherapy offers an alternative approach to empower the immune system to recognize and target the tumor. I'm Allison, and I recently completed my Master of Medical Physics. My project aims to investigate the synergy between radiotherapy and immunotherapy, offering a novel approach to treating mesothelioma. I'd like to thank my supervisor, Martin Ebert, for his invaluable guidance and support during this project. The presentation will commence with an overview of the mechanisms underlying immunotherapy and the researcher's aims and significance. My project is divided into 4 phases. First, I'll outline the methods, results, and discussion for phases 1 to 3, and then I'll outline these details for phase 4. My talk will conclude with an overall discussion to tie the results together, followed by acknowledgements. Immunotherapy, IO, is a promising cancer treatment that trains the immune system to fight cancer cells. Immune checkpoints are crucial for maintaining immune cell tolerance, preventing the immune system from attacking healthy cells. T cells contain CTLA-4 and PD-1 receptors, which binds the ligands on healthy cells, inhibiting T cell killing. Cancer cells evade the immune system by expressing these ligands. The immune checkpoint inhibitors, RT-ICIs, are a kind of IO that block the receptors on the immune cells from binding to the ligands on the cancer cells, allowing the T cells to induce apoptosis in the cancer cells. ICI treatment has improved patient outcomes and long-term remission after treatment ceases. Preclinical studies show IO is effective against murine mesothelioma, both as a monotherapy and with chemotherapy. However, IO is not the standard treatment for cancer due to its limited effectiveness and some patients experiencing adverse side effects from treatment. It is possible that radiotherapy, RT, increases immune system activity against cancer cells. The abscopal effect of RT describes the phenomenon where tumor regression occurs outside of the RT treatment area. The possibility of RT-IR synergy was first proposed in 2012. This hypothesis is supported by Gonzalez-Crespo et al.'s in silico model of the TME, which found RT-ICI combination therapy reduced tumor volume more significantly than either RT or ICI monotherapy. Other in silico models support this hypothesis. However, there is a lack of mathematical models for mesothelioma data. In addition, none of the models comprehensively search the solution space of all possible treatment schedules, only investigating either RT fractionation or IO and RT sequencing. This project aims to investigate the optimal treatment combination of external beam RT and the RT's anti-PD-1 and anti-CTLA-4 using a computational model. The optimal treatment combination maximizes the tumor control probability, or TCP, and is robust to uncertainties in parameters and treatment values. The mechanistic model will also be used to train a reinforcement learning model. While focused on mesothelioma specifically, mesothelioma is an aggressive cancer caused by asbestos exposure. Mesothelioma's poor survival rate can be attributed to its high resistance to treatment. RT is primarily used as a palliative treatment due to a lack of clinical trials and pulmonary toxicity. The standard first line of treatment for mesothelioma is chemotherapy. There will be 4 distinct phases to this project. The first phase will assume that the dose per fraction of RT and ICI remain constant and ignore the effects of tumor vascularization. The second phase will expand the model to consider the effect of tumor hypoxia on treatment efficacy. The third phase will fine-tune the optimum treatment schedule by varying the ratio of anti-PD-1 to anti-CTLA-4 administered. The fourth phase will use the mechanistic model developed in the second phase to train a reinforcement learning algorithm. The reinforcement learning algorithm will vary the RP dose per fraction to maximize TCP. Gonzalez-Crespo et al.'s model considers the growth of tumor and immune cells, the release of antigens from tumor cells, and immune-mediated and radiation-induced cell death. The antigens activate the T cells, which migrate to the tumour and cause immune-mediated cell death. The model of tumour hypoxia assumes a spherical tumour with a hypoxic core in the centre due to the limited penetration of blood vessels. RT preferentially kills normoxic cells, as ionizing radiation creates a peroxy radical in the presence of oxygen, inducing permanent DNA damage. The blood vessels penetrate the hypoxic core, reoxygenating it. Utilizing the Pawsey Supercomputing Center's high-performance computing facilities is necessary to evaluate the multitude of treatment schedules on large sample virtual patients within a reasonable timeframe. In addition, GPUs will be used to accelerate the training of the reinforcement learning algorithm. Gonzalez-Crespo et al.'s mechanistic model for RT and ICI in MATLAB was recreated using Python. A simulated annealing optimization algorithm was used to fit the model to the murine mesothelioma volumes. A sample of virtual patients was generated on Pawsey supercomputer, and the TCP for each treatment schedule was calculated. In this study, TCP reflects the likelihood of complete tumor eradication within 30 days post-treatment. The TCPs were visualized to investigate the solution space around past TCPs. For the third phase, the model with tumor hypoxia was used to evaluate treatment schedules, and the ratio of anti-PD-1 to anti-CTLA-4 was varied. The models were capable of predicting the tumor volume. Untreated murine mesothelioma volumes experienced exponential growth. RT caused a plateau in mesothelioma volume growth, which is slightly delayed due to the mitotic delay between cell damage and cell death. Combining RT and ICIs increase the TCP compared to RT monotherapy, supporting preclinical results that say that the efficacy of RT against mesothelioma improves when IO is administered in conjunction with RT. Gonzalez-Crespo et al.'s model predicted that increasing the number of RT fractions and anti-PD-1 fractions decreased the TCP due to increased tumor repopulation between treatments. However, when hypoxia was considered, increasing the number of RT and anti-PD-1 fractions increased the TCP due to tumor reoxygenation between fractions. Now, let's investigate how TCP is affected by variations in the timing of treatment when tumor hypoxia is considered. Treatment efficacy was maximized when RT and anti-PD-1 were administered early. However, TCP was more sensitive to delays in RT treatment compared to anti-PD-1 treatment. In contrast, delayed anti-CTLA-4 treatment had an insignificant effect on TCP. Increasing the interval between RT treatment days decreased the TCP. The interval between anti-PD-1 treatment days did not significantly influence TCP when tumor hypoxia was considered. However, when hypoxia was ignored, the interval between anti-PD-1 treatment days decreased the TCP. The interval between anti-CTLA-4 treatment days did not significantly influence TCP. The maximum TCP obtained increased when the percentage of anti-PD-1 in the total ICI dose increased. Notably, the maximum TCP obtained when anti-PD-1 was the only ICI administered is lower compared to when 0.38 mg times 2 doses of anti-PD-1 were administered in conjunction with 0.02 mg times 2 doses of anti-CTLA-4. This suggests potential synergy between anti-PD-1 and anti-CTLA-4. A key limitation of this work is that RT was only administered in 1 or 2 life fractions. The recommended radiation dose is 50 to 54 gray in daily fractions of 1.8 to 2 gray for malignant pleural mesothelioma. Dividing RT into small fractions allows early responding healthy tissue surrounding the tumor to repair RT-induced damage, minimizing overall side effects. If the number of fractions are small, a complex RT plan cannot ensure that dose tolerances to healthy tissues are not exceeded. However, incorporating many dose fractions significantly increases the number of treatment schedules that must be evaluated. This limitation is addressed in phase 4. Reinforcement learning algorithms aim to predict the action for a given observation of the environment, which will maximize the expected reward. also known as the Q value for state action pair. The observation of the TME consists of the active normoxic and hypoxic tumor cells. The available actions are the RT doses, and the following two reward functions were optimized. The function R-kill aimed to maximize the TCP, while R-dose penalized treatment schedules with high RT doses. A DQ network, DQN, is a neural network trained to estimate the Q value for a state action pair. DQNs tend to overestimate the Q values due to maximization bias. The Q value is updated based on the maximum Q value estimate for the following state. A deep double Q network, DDQN, removes the maximization bias by using two neural networks to form two estimates. The first is used to select the optimum action, and the second is used to evaluate the Q value. The DQN and DDQN were used to optimize the RT treatment schedules. The results were compared against the baseline treatment schedule of 2 gray daily fractions. All the optimal treatment schedules obtained achieved a higher TCP with a lower bed compared to the treatment schedules in phases 2 and 3, where only 1 or 2 large RT fractions were administered. This highlights the importance of tumor reoxygenation on treatment efficacy. In addition, treatments with smaller RT dose per fraction are preferable, as large RT doses administered in a single fraction increase damage to surrounding tissues, especially late responding tissues. Theoretically, the optimal dose per fraction obtained with the reward function R-kill should be 3 gray administered per fraction until tumor cure is reached. The large dose per fraction not only kills large numbers of tumor cells, but also increases reoxygenation of the tumor, which increases overall radiosensitivity. In addition, the TCP should be highest with the smallest number of RT fractions. However, the network predicts an irregular pattern of dose fractionation is optimal. Both schedules had a lower TCP compared to the baseline schedule due to the fact that some RT fractions were less than 2 gray. It was expected that the optimal total dose with the reward function R-dose is lower than the total dose administered with reward function R-kill. However, this was only true when the DDQN was used to predict optimal actions that maximize R-dose. The TCPs when both networks were used to optimize R-dose were lower than the baseline schedule and the schedules which optimized R-kill. In addition, higher doses were expected to be administered early in the treatment, with the dose per fraction decreasing throughout treatment. Large RT doses at the start of treatment increase tumor cell killing, increasing reoxygenation, which increases radiosensitivity and the efficacy of ICI treatment. The DQN predictions align with this expectation, beginning with a large RT fraction followed by smaller RT fractions. However, the DDQN predicted that smaller RT fractions should be administered first, followed by a few larger fractions, and then lower doses should be administered for the rest of the treatment. Finding the optimal treatment schedule using an IO algorithm is complex due to the nonlinear dynamics of the TME. The results obtained were contrary to the optimal treatment expected by examining the model equations. In addition, it was expected that the DDQN performance will exceed that of the DQN due to the maximization bias present in DQN. However, the DQN which maximized R-kill performed better than the DDQN which maximized R-kill. The suboptimal performance of the R algorithms can be attributed to the lack of hyperparameter tuning, which was outside the scope of this analysis. Future research can evaluate the importance of each hyperparameter and compare the importance values of common hyperparameters in the two implemented models. The performance of the DQN and DDQN declined after more training episodes were conducted, preventing an optimal policy from being obtained. This suggests the possibility of the neural network experiencing catastrophic forgetting, a phenomenon where the neural network weights that allow for an optimal policy in one situation were adjusted to allow for an optimal policy in another situation. Adaptive learning rates and experience replay were utilized in this study in an attempt to overcome catastrophic forgetting. However, the use of suboptimal replay buffer length and learning rate led to catastrophic forgetting. Alternatively, the agent's performance on the testing episodes of RT-ICI treatment could be continuously monitored, and training ceases when performance on the testing episodes declines. In addition, the RL algorithm assumed that interpatient variability was solely due to the variation in the initial number of cancer cells. Variations in parameters such as growth and radiosensitivity were ignored, as the RL algorithm can only observe measurable parameters such as the number of normoxic and hypoxic tumor cells and the cumulative dose administered. As a result, the variation in TCP between virtual patients was negligible. The future research could involve the training of separate RL algorithms for many sets of patient parameters to compare optimal treatment schedules for varying patient parameters. The computational model allowed more treatment schedules to be evaluated while minimizing the need for future cancer treatment trials on mice. The optimal treatment schedule for murine mesothelioma likely applies to humans due to the immune and genetic similarities between humans and mice. An optimal treatment schedule will improve treatment outcomes and palliative care. The model developed can be extended to consider other types of cancers. RT-IL combination therapy could become a viable treatment for mesothelioma in the future, particularly for patients who did not respond to chemotherapy. However, the side effects caused by RT and IL treatment for mesothelioma remain barriers to implementing RT-ICI therapy as a standard treatment for mesothelioma. There are barriers to using this mechanistic model for clinical research. Limited data is available on human mesothelioma patients treated with various combinations of RT and ICI. So a BALBC murine mesothelioma model was used for data fitting. The dataset included only young mice originating from an invert strain. This ignores the effects of aging and genetic variation on treatment efficacy. Many cell processes, such as cell proliferation and death, are slower in humans in comparison to mice. Successful future trials of RT-IL therapy on murine mesothelioma patients could lead to RT-IL combination therapy trials on humans, allowing the model to be extended to consider human mesothelioma. The use of a small dataset may result in overfitting of the data points when determining the parameter values, particularly those with many parameters. The model fitting was divided into stages in an attempt to mitigate overfitting. However, this is unlikely to fully mitigate overfitting. Further studies should validate the model parameters by fitting the model to another BALBC murine mesothelioma dataset, and the optimal treatment schedules determined in this study should be replicated on BALBC mice to determine the reliability of the results. The model assumes the tumor was spherical. This simplification is applicable for some tumors grown in vitro, such as colon cancer and ovarian carcinoma, which have a roughly spherical morphology. However, pleural mesothelioma does not have a spherical morphology. It appears as a line-like pleural thickening or a widespread pattern of discontinuous nodules. Future research could involve modifying the model to simulate the growth of mesothelioma more accurately. The model predicts that delays in anti-PD-1 treatment decrease TCPs slightly for all virtual patients. This is in contrast with the experimental results, where anti-PD-1 had a significant impact on growth for only some of the animals. This is possibly due to the spatial or structural changes of the tumor, which was ignored in the model. Spatial heterogeneity of the tumor and the distribution of RT and ICI drugs were ignored. Spatial heterogeneity is a significant factor impacting treatment efficacy. Hypoxic regions should be targeted with higher doses of RT using dose-pairing techniques, and heterogeneity prevents optimal response to ICIs. It was assumed that tumor reoxygenation occurs solely due to a reduction in tumor volume. However, D'Alonzo and Kim et al. Study shows low-dose RT is capable of remodeling tumor vasculature to improve perfusion and reduce hypoxia without necessarily reducing tumor volume. Future research could involve incorporating the spatial distribution of cells, RT and IO, in the model. Alfonso et al. Spatial example model could be used as a starting point, and it models the impact of RT on the immune system. However, it does not model IO. The mechanistic model developed supported the preclinical observations that combining RT and ICI increased the TCP compared to RT monotherapy due to the increase in concentration of anti-tumor antigens following RT. The TCP was most sensitive to variations in the timing of RT treatment, followed by anti-PD-1 treatment timing. The timing of anti-CTLA-4 treatment had an insignificant effect on TCP. The study suggests the potential for RT-ICI combination therapy to be used clinically to treat human mesothelioma. However, further research into human mesothelioma tumor dynamics and the side effects caused by RT and ICI should be investigated further before RT-ICI therapy becomes standard treatment for mesothelioma. I've submitted the research published for phases 2 and 3, and we'll plan to submit the results for phase 4 for publication in a peer-reviewed journal. And I have also published a literature review about the in silico models used to model the impact of RT-IO on the TME. This project would not have been possible without the preclinical research conducted by Professor Annie Nowak, Dr. Suki Gill, Dr. Alistair Cook, and Rebecca D'Alonzo, as well as Pawsey Supercomputer Sensor Systems. I also want to thank Isabel Gonzalez Crespo and Juan Pardo Montero for their background code of their model and their assistance regarding their code. I also want to thank Dr. Pedro Zashin-Faza and Dr. Jake Kendrick for their excellent teaching and support throughout my project, particularly for giving feedback on my manuscript and helping me with the radiobiology component. I'm also thankful to Associate Professor Du Wing for her valuable assistance for the reinforcement learning component of my project. Thank you.
Thanks very much, Allison. Are there any questions?
Yeah. Allison, that was an excellent talk.
Thank you.
In terms of choice between using supercomputing facilities for this task and doing reinforcement learning, which one would you prefer to use in the future?
Okay, so the reinforcement learning models were also trained on the same Pawsey supercomputer as for just the brute force search of treatment schedules. But I would imagine that once we train our algorithm correctly and tune the hyperparameters, that our reinforcement learning will be more efficient in searching the vast possible number of treatment schedules, especially since you can get as far down to varying the RT dose per fraction. But doing a brute force search will take a really long time and be impractical.
Martin, question?
If there are questions from anyone else in the room, probably prioritise them over the supervisor.
Okay. Yeah. So, Alison, I have a question. Again, really fantastic presentation. So there's lots of work being put into this, and I guess you touched on this in your last slide. And my question is, what do you think needs to be done to progress this to potentially a phase 1 trial of actually testing this in humans?
So probably to progress this further is to improve the reinforcement learning component so that the predictions of the optimal treatment policy are what we expect from the model equations, and also modifying the equations to have the spatial component, because that is quite a significant factor that we can improve tumor reoxygenation without necessarily reducing tumor volume. And as we know, the tumor hypoxia affects the RT and ICI efficacy. So I think once we research more into the tumor dynamics and we consistently find that RT-ICI therapy is effective in mice, then we can start applying that to humans. And also, we also need research into the side effects of RT-ICI treatment, because my model only considers the impact on the tumor cells and immune cells, not the surrounding healthy tissue.
Excellent. Awesome. If you wanted to jump in with your
Yeah,
question.
sure. It's interesting you suggested trying it on human data rather than using the preclinical data, Alison. There's probably not likely to be enough data for mesothelioma because it's not treated with these combinations yet. Would the model work okay in other tumor sites, or what would you need to change in order to apply it to any other tumor sites?
So probably to apply to any other tumor sites, you probably need to redo the parameter fitting process by using, say, data from colon carcinoma or breast carcinoma, because all tumors have different growth and radius sensitivity parameters. So that will affect the optimal treatment schedule. Because this model, the Gonzalez-Crespo model, was actually applied first to murine breast carcinoma.
Yeah, that's good. Thanks.
And is it easy to source those parameter values for different sugar types? From the literature, for example.
I guess you could search it up from the literature, but then part of the issue might be is that my model is using, say, a logistic growth, but then the growth parameters using, say, exponential growth are different. And also usually the radius sensitivity values are for the whole tumor, but then I kind of divided it into radius sensitivity for hypoxic versus normoxic. So hence we needed to conduct the data fitting to existing, say, preclinical or clinical data.
Thanks, Alison. Any other questions? Joel, go for it.
Yeah, great stuff, Alison. If I can ask quickly, do you know roughly what the memory requirements were for model training and inference?
So the model training didn't take too long, probably about like 10 to 12 hours on supercomputer for each stage.
Yeah, the actual sort of VRAM required, like how big the model sort of passes and things were, or is it? I'm not sure if it's different for this model training or for pausing.
Oh, I didn't. I don't recall the VRAM stuff, but then I just know that evaluating all these treatment schedules took quite a few days of just continuous supercomputer running, because I wanted to have like a sample of 500 virtual patients, so that it's large enough to account for like differences in parameter values.
Yeah, so probably a lot.
Yes.
Good. Thanks very much, everyone. That'll conclude the session.